All right, good morning, everybody. Morning, everybody. Can you hear me? Morning, back. Can you hear me up there in the back? All right, perfect. My name is Geoff Maly. I'm a family medicine doctor. I work in Enterprise at Wallowa Memorial Hospital. My background, I grew up in Boston, so know how Doug and I, East Coasters, made our way out here, but we've lived in Wallowa County for 8 years now, and I work in the clinic there, cover the emergency room, admit patients to the hospital, and then I'm also our OB director, so deliver babies, do C-sections, etc. So thanks so much for having me here. My first time talking at the conference and first time giving this lecture. Yeah, here we go. All right, so disclosures. I have no financial disclosures. I do want to thank or acknowledge the American Academy of Family Physicians. They have a advanced life support and obstetrics class, which is what I teach. We teach that at Enterprise once a year. And I borrowed a number of their slides. But yeah, I tried to tailor this lecture to you all. The also course is tailored to doctors and nurses in the hospital setting. And obviously that's not where you're practicing. So, all right, learning objectives. So we're going to talk about some of the common obstetrical emergencies, how to treat those, and then kind of expected handoff and whatnot when hopefully you do arrive to the hospital eventually. All right, so these are the emergencies we'll go through, and we'll go through each of those. So just curious, show of hands, how many folks have had to deliver a baby in the back of an ambulance or at their house or at somebody's house? Okay, got a couple. All right. Any of these things happen to your patients? Okay. Postpartum hemorrhage. Okay. All right. It's probably the most common emergency. So I guess, yeah, point of that is, most of the time, you're not going to have to do a whole lot. Most of the time I go in to do a delivery and, there's not, most of the time these things don't happen. So I think everyone's, blood pressure and pulse goes up when they get a call for a patient in labor or whatnot, but most of the time things go fine. So we're going to talk about when things don't go fine and how to take care of that. But yeah, most of the time things go well. All right, so first topic, pre-labor, preterm labor and pre-labor rupture of membranes. Hi. So you've got a baby with the water breaking, head down, and everything looks pretty good there. So definition of preterm labor, regular uterine contractions with cervical change prior to 37 weeks. And then pre-labor rupture of membranes, we call that breaking water basically before the onset of labor. So risk factors for those things happening, if you have multiple gestations, so twins or higher, if patients had a prior preterm birth, if they've been in any trauma, that can cause a preterm labor and rupture of membranes, or if they have an infection for some reason, which is pretty uncommon in in your setting. So how do you determine if somebody's in preterm labor or in labor? So we call labor, if they're having contractions every 5 minutes or more frequent, I'd assume that they could be in labor. And then obviously if they have a leaking of fluid at home or gush of fluid, we get a call not infrequently from patients at the hospital, did my water break, did it not? And so a lot of times it's hard to tell. I think in your setting, if they're when they sit up or cough and they're continuing to leak fluid, then you'd assume that their water's broken. The treatment and handoff. So, what we want to know when you guys bring them in is, their G's and P's. So how many times they've been pregnant before and how many times they've delivered babies. If you can get their gestational age, time of membrane rupture, and or time of contractions, how often they're having contractions, which you're not going to have a monitor, but they might be able to tell you. Or sometimes patients have timers on their phones, and they'll with a pregnancy apps, it'll tell them how frequently you're having contractions. If they do have leaking fluid, what color is the fluid? Is that dark fluid? Is it clear fluid? Is there a blood? That may motivate us to gather different resources at the hospital. Do they have a prolapse cord? We'll talk about that as one of the emergencies, or if they had a trauma. And then anybody have a way to do fetal heart tones in the ambulance? Anybody have a Doppler? No? Okay. What's that? Never used it. Okay. Yeah. Dopplers come in a couple different, ways. One of they have different probes on the end of them. One can be, for vascular stuff, looking at extremities, or you're getting blood flow there. And those probes don't do super great job of listening to heart tones. So you got to have a different probe on the end. But yeah, if you can get a fetal heart tone, usually just put gel over the middle of the abdomen, right around the belly button, and just go around until you start hearing fetal heart tones. You can get confused. You can hear mom's heartbeat with that as well. So sometimes that can be confusing. But baby's heart rate, normal 110 to 160. So hopefully mom's not attacking away at 110 to 160. And then anybody carry like handheld ultrasounds? No, I think in Wallowa County they do have a point of care ultrasound. So if you do have that, or ability to tell is the baby head down or feet down, that's really going to also help us figure out if we're going to take them straight to the operating room for a breech C-section, or if we can take them to the normal labor and delivery unit for expected delivery. All right. So along those lines, next emergency is a cord prolapse. So here, water's broken and the umbilical cord has come out through the cervix out into the vagina, and the baby's still inside. So that's not a good scenario. Here the baby is breached, which is one of the risk factors for having the cord prolapse. Just anatomically, if the baby's butt down, then the cord has more room and is closer to the outlet, so more likely for the cord to come out. If baby's head's down, usually that'll tamponade the fluid, and so the cord won't come out. So yeah, definition cord prolapse, the cord comes through the cervix prior to the baby coming out. And risk factors, pre-labor rupture membranes or breech. Have multiple babies in there, there's just more space as well. Then if the babies are small, premature, small baby, or if you have too much fluid in there, there's just more room for the baby to move around, and some more likelihood that the cord comes out. So to get a cord prolapse, you got to have breaking of water. And then typically the cord will be out through, out into the outside world, so through the vagina, and so it's pretty obvious. And you can have pretty significant fetal bradycardia, or kind of a dropping of the fetal heart rate with contractions. And that's because the cord gets pinched, and so the baby's not getting blood flow during those contractions. So really, the treatment is to try to restore blood flow to the cord and keep the baby getting blood flow. And we'll talk about how to do that. So treatment handoff, the history is pretty much similar to the last one. All same stuff. For this patient, you probably want to put an IV in, and then if you are getting, if you are able to listen to baby's heartbeat, you notice it's low, or even if you're not, I would probably just start them on IV fluids and oxygen. That's really what we're doing in the hospital if they have a fetal bradycardia, is how do you resuscitate mom to then get baby as much oxygen and blood flow, and that's with oxygen and fluids. So that would be good, regardless of sort of, mom's oxygen level, or how hydrated she is. Maternal positioning is going to be the other key, and I'll show you pictures of each of these. I think it kind of depends on your setting and how you can transport the patient, what you do. So we'll go through. I think I have pictures of each of these things. So oh yeah, this has all the pictures. So what we'll do in the hospital, I've only dealt with one cord prolapse, and that was as a OB fellow, and I broke the patient's water, and right after the water broke, the cord came out, and so I did picture A there, which is you put your hand in the vagina and you're pushing up, putting manual pressure on the baby's head to push it off of the cord, so it's not pinching the cord. So if that happens in the hospital setting, then the nurse is doing that or I'm doing that, and then we're doing that until we can get the patient back to operating room and do a C-section. And really, the patient, the nurse or me or whoever else is there is holding that baby's head up until the baby is physically out of the mom's abdomen. Because again, if that head comes down on the cord and the cord gets pinched, then the baby's not getting any blood flow. Sure.
So if there was the woman who had multiple births, would you see that more often with the cord, or is that usually after?
Sure. So if the moms had like many births in the past, you mean? Yeah, sure. Yeah, that could be a factor. Yep, more room in the uterus and/or more fluid could increase that risk. So, yes, definitely could happen. Yeah. So that's what we do in the hospital, and you could do that. Other things you could do. Picture B is putting a Foley catheter in, and then what you can do is put in 500 cc's of fluid into the bladder, and then blow up the balloon and clamp the Foley. So what you're doing is basically blowing up the bladder with fluid that will then also manually push the baby's head up off of the cervix. So that'd be an option. Probably the easiest, potentially, if you're able to sort of transfer the patient safely, would be to get them on their hands and knees, and that you just are using gravity. So that's picture C there, using gravity. So say, I guess not hands and knees, but knee chest position, so that mom's chest is down, and then gravity is going to pull that baby down to then release pressure on the cord. Other things, Trendelenburg position, you're also doing the same thing there in D. And then E and F are basically bumping the patient, also providing a little bit of bump to the hips to use gravity to try to relieve pressure on the cord. And F just shows mom lying on her left side, which is will also relieve pressure from the inferior vena cava so that the uterus isn't sitting on the vena cava, so that mom gets good blood flow back to her and can then perfuse the baby. So let me see. So I think whatever would make the most sense in your situation and for transfer. I don't know how safe you'd feel transferring a patient in on hands and knees in the back of the ambulance, but I guess potentially how long your transfer is or whatnot. That would be something that you could do. And then, yeah, obviously, if you're able to do an ultrasound in the ambulance, tell us which way the baby's facing. It doesn't really matter because we're going to be cutting the baby out anyways. There's no delivering a baby vaginally with a cord prolapse. So they go to the operating room. And yeah, feel free if you have any questions as I'm going through this, please feel free to speak up or raise your hand. I'll try to look up. So. And folks online, if you want to put any questions in the questions box, I'll try to look at those through the lecture here. All right. And most of the time, these patients actually do pretty well, as long as you can do one of these things to relieve the pressure on the cord. All right. Probably mentioned postpartum hemorrhage being common. This is also fairly common, and some of you may have seen some of these. So hypertensive disorders of pregnancy, preeclampsia being the sort of most common one. So this slide is from the AAFP. I'm just talking about that preeclampsia can affect multiple things. We think about preeclampsia affecting being high blood pressure and causing protein in the urine and causing seizures, which it can do. It can also affect a number of other organs, can cause pulmonary edema, liver injury like HELP syndrome, decreased perfusion of the kidneys, and then obviously can cause poor blood flow to the baby. So IUGR, intrauterine growth restriction, small baby, can cause a placental abruption, which we'll talk about later, and then can cause significant issues to the baby, including fetal death. Most of the time, that also doesn't happen. So. All right, definition of hypertension in pregnancy. I see blood pressure over 140/90. So, normal patient, you're not too worried about a 140/90, but with a pregnant patient, if you get an adequate blood pressure, you think it's an accurate blood pressure, that would be concerning. And then, yeah, briefly, just with terminology, chronic hypertension, gestational hypertension, preeclampsia. It probably doesn't really matter in your setting, but we're looking at, do they have chronic hypertension, high blood pressure before 20 weeks? Do they have gestational hypertension, high blood pressure after 20 weeks, or do they have preeclampsia, which is high blood pressure after 20 weeks, along with spilling protein in the urine? And that happens, you get high blood pressure, it injures the kidneys start spilling protein, and so that's how we make the diagnosis. And then really what would be more concerning are, do they have severe features of preeclampsia, which would portend a more poor prognosis for the mom, as well as increased risk of having an eclamptic seizure. So do they have a blood pressure over 160/110? Do they have a severe headache, bad right upper quadrant pain, which is usually stretching of the liver capsule? Do they have pulmonary edema, or lab abnormalities, which you guys are probably not going to, or may or may not have access to in the field. But if they have a high blood pressure over 160/110 and or a headache, we'll talk about treatment here on the next slide. And preeclampsia and hypertensive disorders, leading cause of maternal mortality in the U.S., as well as morbidity and mortality for the baby. And that's just because it's common. Risk factors, actually risk factors for this: first pregnancy, multiple babies, age over 40, or obesity, or prior history of preeclampsia are the major kind of risk factors. So identification, talked about blood pressure over 140/110, especially worried over 160/110, and if they have symptoms. So typically I would say headache is the most common symptom, which is kind of tough because a lot of pregnant patients are dehydrated, they have headaches, and so we're trying to sort out, is this from preeclampsia or is this from something else? But if they have a high blood pressure, especially 160/110 and a headache, then they've got preeclampsia. You don't need to do anything else. The history similar, also what's their blood pressure in the field and what symptoms do they have. They should also get an IV. You could consider doing IV fluids. Really best treatment, or the treatment for preeclampsia is with magnesium. And they get a 4-gram bolus and then 1 to 2 grams an hour. And that's to prevent them from getting a seizure. If you have prolonged transfer, or they're on magnesium for a while, you've got several hours of transfer, and you're they're on a magnesium drip, they start to get to altered mental status, starting to slow down their breathing. They may be getting magnesium toxic. Calcium gluconate is the rescue medicine for that. I've only seen this in one patient. This is in residency, and this patient was on peritoneal dialysis and had preeclampsia, so we gave her magnesium, and I think we only gave her 2-gram bolus because her kidney, she was on dialysis, so she wasn't getting rid of the magnesium, but that was still too much. So the nurse called me maybe half hour later, and she's like, oh, she's kind of sleepy, and she seems a little strange, and she was yes, not breathing fast, was very somnolent, and we gave her some calcium gluconate, and she recovered quite well. Her mag level, I think, was like 11, which is too high. So good learning case for me. And what else you want to do for treatment? If their blood pressure is over 160/110, giving them labetalol or hydralazine are the blood pressure medicines of choice in pregnancy. That's in addition to the magnesium, because you want to lower the blood pressure, prevent them from having a stroke, And then other things would be seizure precautions, which as typical seizure precautions that you would for anybody who's maybe had a seizure at home and you're responding to their call. So making sure you got suction and oxygen available. And then again, for this would be magnesium. So even if they're on magnesium, they have a seizure in your rig and they're getting magnesium, they need more magnesium. So if they're having a breakthrough seizure while on magnesium, they need another bolus. Usually we give them extra 2 grams. Now, eclamptic seizures usually are, self-limited. They're tonic-clonic seizures, so it's going to be a full, grand mal seizure. Usually whatever 1 minute or 2 minutes or something like that, and then they'll recover like a normal seizure. Patients having a focal seizure or they don't recover, then we worry about, do they have a bleed in the brain or something else. And most of the time, if folks do have an eclamptic seizure, they don't need an emergency C-section. Their baby's heart rate's going to go down while they're seizing because the blood placenta is not getting perfused, but it'll recover. Once they recover, the baby will recover. So we don't typically do C-sections for these patients unless there's some other indication. We'll try to get try to do a vaginal delivery. And then also, preeclampsia can happen in the postpartum period up to 6 weeks post-delivery. Up to like 25% of all preeclamptic patients are postpartum. So it's something we try to tell the patients in the hospital when they're leaving, like, hey, these are the things to watch out for. It's on our nurses' education sheet of educating all patients that leave the hospital after delivery, signs and symptoms of preeclampsia. But something to think about if you're responding to a call and the patient's postpartum and they have high blood pressure and symptoms, then they could have preeclampsia. And you treat it the same way. They get magnesium and they get admitted to the hospital. Yeah, sure. Yes, you could give them benzos. Yep. If they have a breakthrough seizure, I'll give them more magnesium, and you could potentially give them a benzo as well. Yep. Yep. Benzo is not, recommended in pregnancy, but in this case, that's totally fine. So, yep. And probably same doses. It's gonna cross the placental barrier. The baby's gonna be depressed, but if you're keeping the mom alive and from having major injury, then that's appropriate. All right. Okay, next, late pregnancy bleeding. Yes, question. Sure. Sure. Nope, you're right on. And that's why I think, our algorithm in the hospital is if they have a seizure non-mag, they need more mag. So typically we'll do that. I think there is an algorithm. If you give another bolus of mag and their mag level is like near the high end of normal, and they have another seizure, then you might think about adding another anti-epileptic, which in the hospital we probably would use Keppra. Oh yes, right. Yeah, that was my one instruction, huh? Okay. Yes. So I think yes, there is a role for an additional anti-seizure medicine. We would use Keppra. You guys could use benzos. That's fine. But I think yes, the general answer is more magnesium. So. And for folks online, I will repeat those questions when they come up. So sorry about that. Thanks for the reminder, Peter. All right. Okay, late pregnancy bleeding. So most of the time we get a call on folks who are at home and have bleeding, or they come into OB triage, and most of the time it's this picture on the left. They have some spotting. A lot of times, most common causes, they've had recent intercourse or something like that, and they're spotting. Typically, that's fine. So what we're talking about for this lecture is really, late pregnancy bleeding, such as on the right there, where they're bleeding, soaking through a pad or something like that. So late pregnancy bleeding, which, in our thinking, we break it down into, early causes of bleeding or late causes of bleeding. So this would be, near term bleeding, so greater than 37 weeks. And then broken down into life-threatening causes and then non-life-threatening causes. I'll go through the top 3 life-threatening causes there. Non-life-threatening causes: bloody show or cervical change. If patient's in labor, the cervix is stretching, a lot of times they'll have some bleeding, and that's very normal. Won't cause any problems. So if you do notice, they're bleeding a little bit and they're in labor, that's pretty normal. You don't need to worry about the top, couple life-threatening things. Cervicitis, cervical trauma, like minor trauma, such as with intercourse or potentially vaginal trauma, can cause some non-life-threatening bleeding. All right. And then identifying. What do you identify? I identify late pregnancy bleeding. It's really significant bleeding from the vagina. And painful causes: placental abruption and uterine scar disruption, which again we'll talk about here. And then painless causes would be placenta or vasa previa or a cervical polyp. So that's also helpful in us figuring out how to treat those patients and what the cause of the bleeding is, based on are they painful or not painful. All right, so placenta previa and vasa previa. So the picture on the left, there's on the left side, the left-hand baby there, the placenta says normal placenta. The placenta is inserted on the top of the uterus, and that's normal. Placenta previa, the placenta is stuck down over the cervix. Most of these patients will get picked up prenatally, at a 20-week ultrasound. They always look at where the placental location is. So if the patient has gotten prenatal care, don't know how many of your patients get prenatal care, but hopefully most of them, then the patient will know about this already. And most of the time, placenta previa patients, they bleed repeatedly throughout the 3rd trimester, even 2nd trimester pregnancy. So a lot of these patients will have had bleeding before. It doesn't mean they couldn't have significant bleeding, but at least you then may know what's going on, and they may tell you, I have placenta previa. Vasa previa, very uncommon. Patients also should know this from a ultrasound at 20 weeks. And this is where the umbilical cord sticks onto the edge of the placenta, and then the umbilical cord runs right along the cervix. And so if water breaks and the umbilical cord is there, that can tear and start bleeding. This blood is from the baby, not from the mom, so it's coming from the baby. Baby's blood volume is like 350 mils, so they can bleed out rapidly. So this is probably something that would be pretty catastrophic in the field, and you wouldn't know that, placenta previa or vasa previa unless the patient had told you ahead of time. But I've never seen a case like this, or seen a patient that has bled from this. I've seen patients with vasa previa. Those patients have C-sections so that they don't go into labor and have the baby bleed out. Both of those, let's see if I talk about treatment. Yeah, I talk about treatment there. Okay. So yeah, placenta previa, vasa previa, so placental or otherwise problems. Placental abruption. I like this picture. So this is a woman that's got a placental abruption. It causes pain and bleeding. There's the dad who's like freaking out, and he's about to pass out and be your next patient to bring into. Anyways, all right. So placental abruption. There's kind of 2 versions. The more common version is the one on the left, where you have bleeding between the placenta and the uterine wall, and that blood comes out through the cervix. About 25% of the time, you just have bleeding between the placenta and the wall of the uterus, and it doesn't come out, and so you have a concealed placental abruption, so there's no external signs of bleeding. Those are harder to identify for obvious reasons, but more common would be the one on the left. Typically, these patients are very painful. For whatever reason, that bleeding next to the uterus causes a lot of uterine cramping. They'll usually be having like contractions every minute, and they're very uncomfortable, and can have a significant amount of blood out. Major risks for this: high blood pressure can cause placental abruption. Maternal drug use, cocaine, methamphetamine, increases blood pressure, increases risk of having placental abruption. Let's see, trauma to the abdomen, also something that commonly can cause this. So anybody who's been in a motor vehicle accident, and that's why we basically monitor those patients in the hospital. If they have any abdominal pain, as we want to make sure they don't have a placental abruption. Cigarette smoking, yeah, those are the major risk factors. And then uterine scar disruption, very uncommon, but also this is pretty catastrophic. This is early and late presentations of this. So this is a patient that's previously had a C-section, who then goes into labor, potentially at home or somewhere else. We have this a potential risk in Wallowa County. I think none of the hospitals in Eastern Oregon allow patients to do trial of labor after cesarean section, mostly for this reason. So in our county, we have patients that then will deliver at home with the midwife, and so we always worry that this is going to happen, and we're going to have that patient coming in with this problem. So yeah, this is where the uterine scar, where we previously made that C-section incision, is a weak part of the uterus. It's scarred, so the muscle is not as strong. They go into labor, that can tear open. Initially, will cause pain, sometimes external bleeding. As that progresses, the baby may actually exit the uterus into the abdomen. The baby is likely not viable at that time. But yeah, that would be a problem if the patient's been laboring and has had a previous C-section. Then you'd want to think about this being a possibility. Only about, I want to say, like the rate of this happening is like less than 0.5% of all patients that labor after having C-sections. So the rate is very low, but obviously pretty catastrophic. So yes, question.
Another question. So
Sure.
if they had one C-section on their first child, then they're most likely to have a C-section on their second child.
Yeah, so the question is, if a patient's had a C-section with the first child, are they going to have a C-section of the second child? It really depends. I think we typically will refer patients from Wallowa County, we refer patients to Boise or to Lewiston if they want to try having a vaginal delivery after having had a C-section. And for a lot of people, that's very reasonable, having that done in a hospital setting where you're monitored, especially if their first C-section was for something like a breech delivery or some other non-recurrent problem. So we think about if the baby didn't fit the first time and that was the reason for the C-section, it's probably not going to fit the second time. So that's probably not a wise decision. However, if the first time around it was for some other reason and the mom wants to try having a vaginal delivery, we certainly encourage that. We just can't offer that at our hospital, or really, I think none of the small hospitals in Oregon offer that, and mostly that's because of the risk of uterine rupture, the scar coming apart. That happens, you need massive transfusions, et cetera. Most of the hospitals, only carry X amount of blood products and things like that. So it's mostly that is the risk. So yeah, good question. All right, so treatment for these patients. So their history is pretty similar. Also really helpful, as I mentioned before, is like, well, what's their blood pressure? Is blood pressure high and they're having bleeding? This could be an abruption. Is it painful and their blood pressure is high? Well, it's probably an abruption. Did they have a trauma and that's what's going on? Also probably an abruption. Are they having a lot of contractions? If they are, probably an abruption. And then, their abdominal exam. Yeah, if you'll feel fetal parts in the abdomen, that's obviously not a good sign, especially if they've had a previous C-section. Quantifying their blood loss. I can't remember. I think I have a slide on that in a minute, but that's all helpful for you and for us to figure out, how far behind are we when the patient shows up. Are we going to need to be transfusing them immediately? Any of you guys carry blood in your rigs? Nope. Okay. But yeah, I think that's helpful if we know ahead of time. For a lot of the small hospitals like ours, our lab is not in-house all the time. we got to call lab in to like start releasing blood. So if we know, okay, yeah, this patient's had, pretty massive blood loss in the field, then we're going to get lab in there already working on thawing the FFP and getting blood products ready. Yeah, is the baby viable? Is the baby moving? Which can be helpful to tell if the baby's viable. And then can you get fetal heart tones on the baby? And then for them, they're, IV fluids. You can give them IV fluids. Certainly they're hypotensive, or having an abruption, IV fluids. Blood would be more appropriate, but if you don't have blood, IV fluids would be appropriate. And then drawing their blood, drawing a coag as well, would be helpful. And then putting them on oxygen, basically intrauterine resuscitation. I guess the other thing, which I haven't mentioned in here too, intrauterine resuscitation, meaning like baby's not doing well, what do? We give them oxygen, give them fluid, and then get them on their left side to get them off, get mom to have the uterus not sitting on the inferior vena cava, so that blood's coming back up to the mom and can get to the baby. All right, breech delivery and presentation. So breech it comes in a couple of different flavors. Most common being a frank breech on the left, which is the buttocks are coming down first. Baby can also kind of come cross-legged or come feet first. More likely those other two on the right if the baby's preterm or small or whatnot, but more common would be a frank breech. Okay, definition's pretty easy. It's you've got the buttocks or the feet coming through the cervix. Risk factors: small baby, premature baby, high parity. So mom that's had a bunch of deliveries before just has more room for the baby to move around and come down the wrong way. Oligo or polyhydramnio, so too much fluid or too little fluid. Too much fluid, the baby's moving around, doing somersaults, and that's not great for when you're ready to when the water breaks or they go into labor. Or too little fluid, or the baby gets sort of trapped in one position, and that could be breech. Prior breech delivery, maybe there's a problem with, or not a problem, but maybe the mom's pelvis is shaped a little differently, so that babies come down upside down or right side up, depending on, I guess, how you look at it, or multiple babies. The only breech delivery I've done in the hospital is on twin deliveries. So we typically will deliver the second twin breech if we deliver the first baby head down and the second baby comes breech, that's fine. Once that cervix been fully dilated, then it's usually not a problem to get the other baby out, no matter breech or head first. So yeah, identification. Yeah, you do an ultrasound or whatever's coming through the vagina. You look there. There's the buttocks or there's feet. You know what's happening. So yeah, don't panic. We're yeah, easy for me to say. I'm in the hospital. I have great respect for everything you guys do. Not being in the hospital, like I said at the beginning of this lecture, I do these teaching for nurses and doctors in the hospital setting, and try to tailor this to what you guys have available to you in a resource not as rich environment. So we'll go through kind of some of these steps to deliver the baby. Similar to with a cord prolapse, I think the easiest thing to do is get the mom on her hands and knees, and that's the best way to deliver a breech baby, or to have them push out a breech baby. Once the baby's out, dry, stimulate, suction, NRP if needed, focusing on positive pressure ventilation. Anybody certified in NRP? Oh, a couple folks. All right. NRP, neonatal resuscitation. We have our paramedics at the hospital do NRP so they can help us if we don't have our respiratory therapist available, which is not infrequently. So they come in and help us do NRP on babies that need it. The baby comes out, you can leave the placenta in there, that's fine. Talk about a reason why you wouldn't want to leave the placenta in there in a couple slides. Put IV in for mom in case she bleeds or whatnot. And then, keeping track of things would be helpful for us. Time and delivery, how did the baby come out? Did you need to get the mom on hands and knees? What else did you do? Did you need to resuscitate the baby? And then if the placenta did deliver, time that came out. So I won't get too detailed on these, but I think the big, let's see, this slide talks about it. So These are the 10 upright steps, or 10 steps of an upright breech delivery. So upright meaning mom's on hands and knees rather than on her back. So on the left side is sort of what happens normally. So baby's butt comes out, baby turns to sacrum anterior. So that means that the baby's sacrum is facing the mom's front of her body. So in this case, the baby is facing upright if she's on hands and knees. The legs come out spontaneously. It talks about this chest cleavage, which is kind of funny. I'm not totally sure about that, but basically you can see in that step number 4, the baby's out, the arms are still up inside and is doing fine. Next steps, baby will do some flexion. You can see the baby doing like a crunch here. Then step 5, step 6, the arms will release spontaneously. And then 7 and 8, the head comes out, and there you go. So that's what happens. And again, most of the time, say most babies can deliver breech. We don't deliver breech babies in the hospital unless they're a twin, second twin, mostly because of the risk of a baby getting stuck coming out or getting their head trapped in the cervix. That's only about like a 10% or less risk, but we think that's probably inappropriate amount of risk. So any breech baby who doesn't turn, we can't turn. Prior to labor, we do a C-section for those patients. This is kind of a busy slide, but major top thing there is the baby following the normal mechanisms? Is the baby coming out kind of in expected fashion, as we just talked about? If they are, don't do anything. This baby will deliver on their own, and you don't have to do anything. So it says, yeah, do nothing, sit on your hands if you must. And then, yeah, encourage maternal positioning, and I would again encourage them to be on their hands and knees for delivery like this. Is the baby not coming out? Is there some other issue? And how do you identify that? So on the left side, you know, reassuring signs that the baby's doing fine is like the baby has good tone, is doing some flexion, is tummy crunches. The cord is blue, which is good, and has some coils in it. And that would mean the baby is really doing fine, so you don't have to do anything. Signs of impending compromise, the cord starts to get limp or uncoiled, and then current compromise is the baby has poor tone, the cord's flat, white, and limp, yeah, it doesn't look good. So that would be like, okay, if that's happening, then the baby is probably stuck and you need to try to do something. So what do you do? A couple things you could do. This is to rotate the baby to get the arms out and to get them, if their arms are stuck. A lot of times their arms will be in front of them, but their arms are stuck behind them, behind their head, then they won't come out spontaneously. And so the idea here is that you're gonna try to, or you or us, if they come into the hospital, we're gonna try to rotate the baby to get the arms to swing out in front of their face, and then they will deliver spontaneously. So this talks about grabbing the baby, pushing up into the abdomen, and trying to rotate the baby either way to get the arms to come out. This is a shoulder press if the head seems to get stuck. And this is all about flexing the baby's head so that the head can come out underneath the mom's pubic bone. This is putting pressure on the chest of the baby to then get the baby to put their flex their neck and then deliver their head. May require a significant amount of pressure. This is what we'll do in the hospital, because most of the time these folks are delivering on their back, because a lot of times if it's a twin, they have an epidural, so they're not on their hands and knees. This is what I'll do if the baby's head is stuck, is reach my hand in, put my hand on 2 fingers on their maxilla and push down to flex their head. And if I have an assistant, they'll push on above the pubic bone to push pressure on the back of the head to flex that head. And so once the head's flexed, that decreases the width of the occiput to then come out underneath the pubic bone. Okay. So hopefully that doesn't happen to you, but if it does, most of the time, babies will deliver spontaneously on their own with the breech delivery. All right, shoulder dystocia. All right, we got 15 more minutes. Okay, so this is where the baby's anterior shoulder gets stuck against the mom's pubic symphysis. And we really call it a shoulder dystocia if it's taken more than 60 seconds that the head delivers and the rest of the body doesn't deliver. Risk factors: big baby, mom with a previous shoulder dystocia, and then identification is the head delivers, but the rest of the body doesn't deliver. And again, for more than 60 seconds. What can also be sometimes sort of disconcerting is the baby's face will start to turn blue, and that indicates that the clock is ticking here to get the baby out. Let's see. So this is just a picture of what that looks like. So this baby's trying to deliver. There's the doctor or the EMT or paramedic trying to help guide the baby's head out, and the anterior top shoulder stuck against the mom's pubic symphysis. All right. So what do you do? So first you should panic. You don't actually panic. You got 5 minutes, but you only have 5 minutes. So you want to, you can panic after 5 minutes, but pretty similar to everybody else, getting them on hands and knees. A lot of times it uses gravity to get them sort of in a different position and disimpacts that shoulder. So you can get them on their hands and knees, then try to gently pull traction on the head, and a lot of times the baby will deliver. So yeah, maneuvers: gentle axial traction on the head, meaning in line with the rest of the baby's body. You don't want to be kind of pulling, yanking down or up on the baby's head, just pulling straight out the direction of the baby's coming out. Things we'll do: I'll show pictures of these. Elevate the legs, suprapubic pressure, getting the posterior arm out. It's all stuff that we would do in the hospital. Typically, I'll do those because most of the time the patient's on their back, and so I can do these things quicker than it takes them, especially if they got an epidural, to like roll over and do the hands and knees. But in your setting, they're not having an epidural, so get them on their hands and knees and see if you can deliver the baby. If you can't, then I get them back on their back, and then you could do these things. It is a little bit weird, it's got a head sticking out of the vagina, and you're getting them to kind of move around, but that's fine. They're not going to injure the baby. Put an IV in, and then notation is like, what time did the head deliver? If you can get somebody or document somehow what time did the head deliver, which shoulder the baby was impacted. So a lot of times I'll just think about when the baby came out, was the baby looking to the mom's left or looking to the mom's right? And then you can tell us which shoulder that was. What time did the body deliver, and then any resuscitation you needed to do for the baby. So yeah, studies show you got 5 minutes until the baby has decreased blood flow, and then to the point where they're going to get acidotic and potentially have brain damage, that type of stuff. So I'll go through these quickly. One, roll the patient, easiest thing to do, and that will help increase the pelvic diameter and hopefully get the baby out. You see gentle axial traction on the head there from that picture. Number two, legs. What we'll do, put the legs up. This increases the pelvic diameter. This is called the McRoberts maneuver for whoever McRoberts was. But most of the time, we'll do this and then do this, which is suprapubic pressure. So similar to the breech delivery, pressure right above the pubic bone. That will disimpact the shoulder from the pubic symphysis, and then you can deliver the baby. So most of the time, I'll do these two maneuvers, and then we get the baby out. After 60 seconds, if I haven't gotten the baby out doing this, then I will go in and grab their posterior arm. So reaching in whichever way the baby's facing. Baby's facing to the mom's right side. I'll use my left hand basically to go in front of the baby's head. Reach for that arm, try to pull it up and in front of their face. Once you deliver that arm, then the rest of the body will deliver. You can break their humerus, which I've done before. Babies are very pliable. They don't notice. It doesn't seem like it, at least. They never told me that. And they heal on their own. There's no, we don't splint them. They don't need surgery. And getting the baby out instead of having a baby with cerebral palsy or asphyxia or something like that is certainly preferable. So I've broken humeruses or broken clavicles doing this, and they do fine. So if you do that, that's okay, especially if you got the baby out. These things are ways to kind of try to disimpact the shoulder. Won't go through. I usually don't do these because usually I'm able to get the baby out with the first few. And I think for you guys, hands and knees is the ticket. All right, postpartum hemorrhage. Definition greater than 1,000 blood loss or bleeding, active bleeding. You don't know how much they lost and they're hypovolemic. Well, they've got a postpartum hemorrhage then. Risk factors: a previous postpartum hemorrhage, they have abnormal placenta, really big baby. If they're big, if they had initial anemia or an infection, are all risk factors for postpartum hemorrhage. So identification: they've got a bunch of blood coming out of the vagina, and typical vaginal delivery, 250 milliliters is not uncommon. Up to 500 milliliters, not that uncommon of blood loss, but really anything above that, they're probably going to start to have signs of hypovolemia and they've got a postpartum hemorrhage. So most common cause, decreased uterine tone most of the time. So the uterus is just floppy and needs to contract. Other causes: trauma, cervical lacerations, tissue, meaning retained placenta. These are things that generally you wouldn't have to worry about. All right, there's a picture of bleeding. I thought this was kind of funny. The bottom says, bed with a puddle of blood on the sheets, probably less than 1,000, and vaginal bleeding with blood flowing onto the floor, probably more than 1,000. It's like, it doesn't, if you got blood that's puddling on the, in the gurney, then you probably hit it. If there's blood flowing on the floor, you've definitely reached your need to resuscitate. All right, treatment. Really, you guys are probably pretty good at this. Resuscitation of the mom. So, if you can get labs, CBC, CMP, if you do type in screens or coags, IV fluids. If you've got blood products, major medicines we give patients. Pitocin is the first one. I don't know what you guys carry on your ambulance if you have any medicines or if anybody has medicines, but Pitocin would be the first treatment. TXA would be also appropriate. TXA dose is either 1 to 2 grams, whatever you have. I think our standard is 1 gram. Trauma standard is 2 grams. It doesn't really matter. Whatever you have would be appropriate. And then, if the patient's delivered, the baby's out, and there's massive bleeding and the placenta's in there, then you got to try to get the placenta out. And so we'll talk about how to do that, because once the placenta's out, that uterus can contract, and that patient will then stop bleeding. And you can also do other bimanual uterine massage. So this is just pulling the placenta out. So it's called the Brandt maneuver. So you put gentle traction on the cord, and then you're pushing right above the pubic symphysis upwards on the uterus, and that's so that you don't pull the whole uterus and do a uterine inversion as you're pulling the placenta out. That's obviously another problem. Yeah, you're basically putting counter traction against yourself pulling on the cord. And again, I would only do this if they're massively bleeding and the placenta is still in there, and we got to try to get the placenta out. Once the placenta is out, if you're still first treatment would be uterine massage, so just mashing on their uterus. They're going to hate you, so they're probably going to need some pain medicine, or you're just going to have to say, hey, I need to do this. You're bleeding excessively, and I'm worried about your safety. They will be very uncomfortable, but that's okay. Massaging their uterus aggressively for 5 to 10 seconds. They're still bleeding. This is a bimanual uterine compression. Taking your whole hand through the vagina. You might need to lubricate that up if you have large hands. And then once you're into the vagina, making a fist and pushing against the uterus with your other hand on the uterine fundus to then basically compress the uterus against your hands. And I would say that's like, last stage. If medicine's not working and uterine massage is not working, if they're still bleeding out, then this is what we do in the hospital until we can get like a balloon inside of there or some other device to better treat their uterine atony. All right, I think, let me see, this is my last, yes, okay, so trauma, last topic. So trauma and resuscitation in pregnancy. On the right-hand side, this is causes of cardiac arrest. Non-OB causes, which you guys are all familiar with, I'd imagine. OB-specific causes, we talked about a lot of those already. Eclampsia, HELP syndrome, which is part of eclampsia. Extra magnesium, postpartum hemorrhage, preeclampsia, urine atony. The only one we didn't talk about is amniotic fluid embolism, which I have a slide on at the end here. Briefly, physiologic changes in pregnancy. Mom's blood volume will increase, plasma volume increase by 40 to 50% in pregnancy. And during pregnancy, the uterus receives about 30% of cardiac output compared to only 2% in a non-pregnant uterus. So it's getting a ton of blood flow. And then if mom's laying flat, their blood flow to the baby is going to be decreased because of that, the baby sitting on the inferior vena cava. And then unlike cerebral perfusion, there's no auto-regulation for uterine blood flow. So if the mom's blood pressure is low and they're not perfusing, then the baby's not going to get being perfused either. There's no way for the placenta to adjust like your brain does to poor blood flow systemically. You can have a lot of blood loss before you see signs of hypovolemia in pregnancy. So if it seems like there's a lot of blood loss, but they're still normotensive, treat them like they've had a lot of blood loss, because they probably have. And signs of shock can be late in pregnancy, similar to kids. They'll kind of cruise along, and then all of a sudden they'll fall off the cliff, and you don't want to fall off the cliff. So trauma resuscitation or cardiac arrest, it's the same ACLS, BLS stuff, standard treatment. The only thing you do differently is uterine displacement, which I have a picture of. Here's I think the medical student or whatnot pushing on the uterus to displace it to the left during a code. Positive pressure ventilation ASAP. Mom has a smaller tidal volume in pregnancy because the uterus is pushing up on the diaphragm. So trying to ventilate them as soon as possible. Smaller ET tube size because there's more swelling in the airway in pregnancy. So and then use normal drugs and normal joules for cardiac arrest. And then if this happens in the hospital, our goal, if the mom is coded, is within 4 minutes, we want to cut the baby out. We do that in the emergency room. Don't bring it back to the operating room. And really the goal is that you get the baby out, and once the baby's out, that 30% of blood that's going to the baby now becomes more like, the 5% or 2% or whatever. So then mom can use that blood to circulate her brain and her heart, and then you can start working on the baby. Let's see, last two slides. So motor vehicle collisions briefly, most leading cause of death among pregnant people. And 50% of all trauma that happens in pregnancy is from a motor vehicle crash. Another unfortunate large percentage of trauma is from intimate partner violence during pregnancy, which is also more common, unfortunately. Normal seatbelts, there's no reason to not have a seatbelt on, and have an airbag if your car has those for a pregnant patient. Amniotic fluid embolism. This happens to you guys. There's not a lot you can do. If it happens in the hospital, there's not a lot we can do either. This is an anaphylactic reaction to amniotic fluid. This causes basically a rapid deterioration of the mom. She'll be in a code situation and whatnot. So you would treat them as you would a normal code patient. All right. I guess thank you all for all you do. Working in Loudoun County, we rely on our EMS folks a lot to help us out both in the hospital and bringing us patients. Great respect for everything that you guys do. Yeah, thanks for all your hard work. Thanks for having me here.